I'm going to turn it over to Gabrielle Rex, who is moderating tonight. And she is our nurse practitioner in the memory care program. So I turn it over to Gabrielle.
Great. Thank you so much, Nori. So the Caregiver Support Program of the Dementia Care Collaborative was started at Mass General Hospital in 2017. We are part of the Palliative Care and Geriatric Medicine Division. And if you scan through the little Zoom boxes, you'll see we are joined tonight by some of those who really make this program possible. And that's Susan Rowlett, the program director, Barbara Moskowitz, who's the founder and associate director of education and support, Chris White, who's a social worker with experience in neurology and covering with our memory care initiative in the primary care setting, and Kelsey Anderson, who is a social worker in the memory care initiative, as well as Nori, who is our program coordinator. As many of you know, the mission of our program is to transform memory care. We exist at MGH to educate, connect, and support patients, caregivers, clinicians, and the larger community. We offer care consultations to care partners and patients in specific MGH clinics, skills classes for caregivers, support groups, and health and resiliency classes as well. The Caregiver Support Program is entirely funded through philanthropic support. So if you're interested in learning how to support our program, please reach out to one of our team members. And now, without any further ado, I'd like to introduce Dr. Erin Stevens, tonight's speaker. Erin Stevens is the geriatric and palliative care physician at the Ohio State University Wexner Medical Center and James Cancer Hospital. She developed and serves as director for the Care PAL Clinic and provides geriatric and palliative care as part of the Cancer and Aging Resiliency Clinic Care. Dr. Stevens was my mentor as I began stepping into this work. She serves as the medical director for the Memory Care Initiative, or served as the medical director, part of the Dementia Care Collaborative in its beginning stages. If you hear some noise in the background, it is probably Dr. Stevens' 2-year-old son and 2-year-old chocolate lab playing together downstairs. It is with great pleasure that we invite her back to speak today.
Well, thank you, Gabrielle, for that warm introduction. Let me just pull up my slide deck and make sure that everyone can see it okay. 1 second. Okay, can we see the slides okay? Okay.
Not yet.
Okay. All right. I want to thank you for making the time to attend our presentation this evening, Memory in the Mind and What You Should Know. As Gabrielle mentioned, I'm Erin Stevens, a geriatric and palliative care physician, and I've had the honor to work here at MGH, as she mentioned, with the team. It's a privilege to be back here and talk with you tonight and be back a part of the team.
Erin, I think to just stop to pull up the slides too.
Oh, can you not see the slides?
We cannot see them.
Just the share screen.
Take your time. We're working with technology.
Yes. It is showing up on mine. Let's see. Little technical difficulties. Share screen.
Mm-hmm. Great.
Are you able to see?
Here we go. Now we can see that.
Yes.
All right.
Thank you.
Okay. As I was mentioning, it is good to be back here, a part of the team. I am now a little bit closer to my family in the Midwest here in Ohio, and I'm currently working with older adults at the Ohio State University who have cancer and memory concerns. As Gabrielle mentioned, at the end, we'll have time for questions. And certainly if something comes up along the way, feel free to message or ask it in the chat and we can address it at the end. Did the slide advance okay?
Yes.
So what I'm going to talk about today, I'm going to review normal memory changes associated with aging. I want us to understand when and how to seek evaluation. We're going to recognize some of the different types of dementia and how this is different from age-related memory changes. And finally, we'll discuss current treatments and interventions and strategies you can do to maintain a healthy mind. I want to first start out by talking about normal memory changes that occur as a part of aging. This is called cognitive aging, and it's a process that begins at birth and continues throughout life. And this is not a disease. It's a process that happens in all of us. So think about learning a new task, such as how to work a new television. Maybe you're able to figure out how to use the television, but it takes a little bit longer, but you still are able to figure it out, and you can remember the steps to do it at a later time. Let me walk you through another example of normal age-related memory changes. So I'm sure many of us drive a car or have driven a car in the past. And have you ever gotten to the parking lot and forgotten where you parked your car? So that kind of memory lapse is more likely to happen as you get older. Maybe your brain is sorting through those where did I park my car memories to find their correct location. And that's normal cognitive aging. That is a very normal process. What is not normal, however, is to get to the parking lot and to forget what kind of car you're driving. So cognitive aging is different from dementia. With cognitive aging, you see the memory changes do not affect your ability to complete tasks or function independently. Thinking back to our car example, forgetting where we parked doesn't keep us from eventually finding the car and driving ourselves home. So here are more examples of memory changes associated with aging, and they're compared to symptoms that are concerning for dementia. I would like to highlight a few of them. For example, if you think about typical aging, you may complain of memory loss. Maybe you are talking to a friend about a new restaurant you went to last week, and you can't remember the name of it. You're able to describe that it's a seafood restaurant in the Braintree Shopping Plaza, and then either you can remember the name or you've generated enough information that your friend can guess the name of the restaurant. And when they name it, you're able to recognize the name and say, yes, that's exactly where I ate. So that is normal. What is more concerning is when you're talking about the restaurant, you're unable to generate any kind of details with it. You can't remember the location, the type of food that was served. And if your friend guesses it, you may or may not recognize that that's the correct name of the restaurant. That's a little bit more concerning. And you can see other examples here of typical aging versus symptoms of dementia that you can read through a little bit later. So now we've learned a little bit about healthy age-related memory changes. Realize it can be very difficult to tell the difference between this and dementia. So if you see here healthy age-related decline, you see that it does not affect independence. This doesn't affect your function and you're still able to go about your day. Dementia, on the other hand, does. And so you can see here that there's memory decline over time and then eventually does affect independence and function. And then there's this other category here in the middle called mild cognitive impairment that you see as that state of cognitive decline before function and independence is affected and formally diagnosed as dementia. We'll talk about that a little bit later, but the point I really want to emphasize on this slide is that there are two paths that subtly diverge over time, and it can take some time before we can make a definitive diagnosis of dementia. It's important to understand that not all cognitive problems or dementia present with memory loss. There are 6 main mental areas or domains in our brain, and depending on where the impairment is, determines an individual's deficits in presentation. And these domains are complex attention, executive function, learning and memory, language, perceptual motor, and social cognition. You can see the descriptions for each are listed. For example, learning and memory is the ability to retain and manage new information. A deficit there might present as someone repeating themselves in conversations. And social cognition is the ability to recognize and display socially appropriate behaviors and emotions. So deficit in that might be not noticing that you're using inappropriate language in situations where you shouldn't, or maybe not responding correctly to someone's emotions if someone is crying or upset, not recognizing that you might need to change the way you're talking or behaving with them. Those would be concerning features. So each of these 6 areas has a very specific location in the brain. Depending on where there is brain injury, the symptoms can vary. For example, with Alzheimer's dementia, that affects the sides of the brain, the temporal lobes, And that's why when you see patients with Alzheimer's, one of the things that they often complain about is memory loss very early. In patients that have frontal lobe damage, such as with frontal temporal lobe dementia, they often present with problems with their behaviors. They may be socially inappropriate, but often their memory is preserved very early on. And as frontotemporal dementia progresses, it involves the temporal lobes, that's when we start to see memory affected as well. So understanding these cognitive areas in the brain is important because memory loss may not be the initial symptom. And even if it is, people for many reasons may not bring this to medical attention. So difficulty with memory can present as forgetting tasks, such as how to shop or cook. And so they might present with weight loss. Managing medications can become challenging, and sometimes that might get mistaken for non-adherence. We can see concerns if someone's dressing inappropriately for the weather. So going out to work or coming to the doctor's office in the very frigid Boston winters and minimal clothing can be very concerning. And someone who's always well groomed and put together, all of a sudden becoming more disheveled, it can be concerning. We also hear that sometimes a loved one may be starting to spend money inappropriately or accusing partners of cheating or stealing. And that can be signs that there's issues going on in the front part of their brain, and a sign that something's going on and needs to be evaluated further. So anything I have listed here can be a concern that maybe we should be looking at memory and exploring further. And so I've spoken about normal memory changes that occur as we age, as well as memory changes that are more concerning. And maybe you or a loved one has noticed this, and you wonder if they need further evaluation. And so often people say, well, I've noticed something, so where do we go from here? What do I do next? Who do I go to? So, many providers can perform an initial evaluation and make a diagnosis of dementia. And depending on the symptoms or presentation, that may determine whether or not someone might need to see a specialist. A good place to always start, though, is with your primary care provider, as he or she most likely knows you best, and they can determine if a specialist might be needed and place that referral for you. But to be aware that anyone on the slide here, a geriatrician or neurologist, psychiatrist, can make this diagnosis as well. So when we are able to make a diagnosis of dementia, this is a clinical diagnosis. What I mean by that is that there isn't a specific test or image that can say with 100% certainty that this is dementia, this is Alzheimer's dementia, frontotemporal dementia. So, and the way we make this diagnosis is we do a full history and exam, we do cognitive assessments, we look for reversible causes. And as I mentioned earlier, sometimes we have to follow folks over time before we can make a diagnosis. There are some brain imaging and lab tests that we can do along the way, and those with the history and physical exam may be suggestive of the diagnosis. So I mentioned reversible causes, so let's talk for a few minutes about those. I have here listed on the slide some of the causes of memory loss grouped together by different systems in our body. And you can see here that there are several listed, and all of these listed can present with memory problems or cognitive issues. The ones that are still that are highlighted in black that you're able to read, those are the ones that are actually reversible. And as you can see, there are quite a few listed. And so this is why it's important to first start with your primary care provider and let them know that you're noticing some memory changes, some issues, because they'll do a full history and exam and look for any of these causes that might be reversible. There are many laboratory tests that might be indicated based on the history and physical exam, and many would agree that the laboratory tests I have listed here should be included in the initial evaluation of a memory complaint. It's not uncommon to have someone present with fatigue and memory problems and then perform one of these labs and to see that the thyroid function is off and have a new diagnosis of thyroid disorder. So be aware that there are reversible causes and have a full history and exam. And depending on the symptoms or history, your provider may order more labs or more tests than what's listed here. And with regard to imaging, Not everyone needs head imaging, although the American Academy of Neurology does recommend imaging for everyone. And depending on the history or symptoms, a non-contrast head CT might be the quickest and most cost-efficient test. There are criteria for when head imaging should strongly be considered. I have them listed here. So if there's memory problems that occur before the age of 65, if you ever had a fall and hit your head, if you're noticing symptoms come on suddenly and are progressing quickly, or you have some kind of neurologic symptom where maybe you're having trouble moving your arm or leg, those are all concerning history features that you probably should have an image done to look, make sure that everything's going okay in the brain. A key part of our evaluation when someone is worried about memory loss is performing one of these brief assessments I have listed here. So some of you may already heard about the Montreal cognitive assessment known as the MoCA, or the clock drawing test, or the mini mental state examination. It's important to know that these tests should all be done in the outpatient setting, not when someone's in the hospital and has just had a procedure and not at their medical baseline. You certainly wouldn't want to perform these tests if someone's getting their days and nights mixed up and just not their usual self. And something else that's important to know is that these tests cannot make a diagnosis of dementia. Realize that someone who is well educated may score 100% on any of these assessments, but still may have something going on. And someone with a learning disability, such as dyslexia, may not perform well on these, and it doesn't necessarily mean they have a memory issue. In these situations, what we would do is refer to someone for a more in-depth assessment called a neuropsychological assessment. I've talked a lot about the evaluation for dementia and said that it's a clinical diagnosis, but how do we make a diagnosis of dementia? Well, I showed this graph earlier in the presentation where I mentioned there's two paths, healthy age-related cognitive decline and dementia, that subtly diverge over time, and it can be a challenge to really know which path someone is on. So dementia is formally diagnosed when memory problems start to affect someone's function and independence, that you can see here represented by the shaded gray box. So what do I mean by function independently? Well, here's a list of functional activities we ask about when someone comes in complaining of a memory issue. And these are the activities that we want to know if the memory is affecting. So these items on the left are known as instrumental activities of daily living, or IADLs, and the activities on the right are the activities of daily living, also referred to as the ADLs. And so you can see on the left, we've got shopping, managing medications, driving, managing finances, and those on the right is those more intimate daily activities like bathing, getting dressed, feeding yourself. One way to think about these activities are the ones on the left are those that you might want to pay someone to do for you, and those on the right are the ones that you hope you never have to pay for someone to do for you. So when a memory or cognitive problem is affecting your ability to complete these tasks, that's when we can make a diagnosis that there is a memory problem that's most likely dementia. So I'm talking about dementia, but I want us to all be aware that this is an umbrella term that describes a disorder, but it's not a specific diagnosis. If you think about cancer, that's also an umbrella term. There are many diagnoses within it: breast cancer, prostate cancer, and so forth. So dementia tells us there's a disorder, but realize that there are several specific diseases listed under the umbrella of dementia, and I have some of them listed here. Alzheimer's is by far the most common dementia. It accounts for about 70% of cases. And you can see here the many other specific dementias that make up the remaining 30%. While there are many different types of dementia, there are some that are more common, and I wanted to review those with you tonight. As you can see here, there is a disorder called mild cognitive impairment, or MCI. This is now being referred to as mild neurocognitive impairment. This may or may not progress to dementia, and we'll talk about this on the next slide. And you can see here there are other types of dementias listed that I'm going to talk about further. So people with mild cognitive impairment, or MCI, commonly have mild problems performing complex functional tasks such as paying the bills, preparing a meal, shopping, and it may take them more time to complete the task and be less efficient. Maybe there's more errors. but nevertheless, they can complete the tasks and maintain that function and then independence. When we do our testing, we're able to detect the deficits in this. For example, when we do the mini-cog or MoCA, we might notice that they have difficulty recalling some of the words we've asked them to remember. This is different from healthy age-related memory changes where we don't see any impairment with our testing. Approximately 15 to 20% of people age 65 or older have mild cognitive impairment from any cause. And people with mild cognitive impairment, especially those involving memory and short-term memory, are more likely to develop Alzheimer's or another dementia. What they estimate is about 12% of people with MCI will progress to Alzheimer's dementia per year. So I want to talk a little bit more now about other common types of dementia. We'll first start with Alzheimer's dementia. This is often a gradual and often insidious onset where people often can't tell you exactly when they begin to notice memory issues. Often the first symptom or complaint is short-term memory problems and difficulty recalling recent events. You may often hear someone say, mom's long-term memory is great. It's just a short-term event. She just can't seem to remember. When we do a physical exam, there may or may not be much that's concerning or out of the ordinary. We also notice that in these folks, social behavior is maintained and that the decline can happen slowly over years. We know from imaging and studies that with Alzheimer's dementia, the damage involves something that's called a neurofibrillary tangle. These can accumulate in very specific locations in the brain. I have those areas represented here with the yellow-orange on the screen. This is a CT image of the brain, and it's a coronal cut of the brain. So if you were to take a cut sort of down from the top of your head down through like this is the cut that's represented here. And the arrow is pointing to a region in the temporal lobe of the brain called the hippocampus. And this is where we see changes in Alzheimer's dementia. And as you move from the normal brain on the left to dementia on the right, you can see the arrows pointing to a gray area in the brain where that gray area is getting smaller and the black space is getting bigger. And that's showing that with Alzheimer's dementia, that part of the brain is getting damaged and shrinking. Now, this doesn't make a diagnosis of Alzheimer's dementia, but you can imagine with a history of a gradual onset and short-term memory loss and so forth, that this image could help clarify that Alzheimer's is most likely the diagnosis. And I say most likely because the only true definitive way to know for sure is if someone were to have an autopsy after they passed and they were to see those neurofibrillary tangles that we talked about on the previous slide. Vascular dementia can be variable in how it presents because this is usually due to vascular damage in the brain, such as with a stroke or high blood pressure over time. People can often be a little bit more exact in pinpointing when they notice the change. They may tell you something like, Dad was doing well until late summer and something seemed to really change. And then what we might hear is that things are stable for a period of time, and then there's a noticeable time when something seems to change again. We call that a stair-step pattern, and we see that sort of often continues throughout the disease. And really the symptoms of presentation really depend on where the blood vessel injury is occurring in the brain. If damage is more in the frontal lobe, you could see problems with planning and completing tasks, with memory relatively being okay. Usually there can be subtle differences in strength and movement of the arms or legs on exam. And again, we usually see a stepwise decline over time. With mixed dementia, the brain changes are often due to both of those neurofibrillary tangles as well as some vascular injury. So initial symptoms can vary from short-term memory loss or something else, such as staying organized and planning tasks. And with this, you can see both a gradual decline as well as that stair-step decline we talked about a few minutes ago. I think frontal temporal lobe dementia is one of the harder dementias to diagnose, as it can be gradual and subtle. And because the damage is in the frontal lobe where our behaviors and our complex attention and tasks is located, the initial symptoms might be inability to complete work, changes in behavior with inappropriate comments or gestures. Realize that this disorder is twice as common in men and often has an earlier age of onset in the 40s or 50s. Many cases are familial, meaning that it's present in several generations of family members. And often the story we'll hear is that a young man was becoming more disorganized and not performing well at work. Maybe he got fired. Their partner may say that they've noticed personality changes, and many may separate or actually get a divorce thinking that the personality change is intentional. And as these patients progress, they can lose the ability to recognize faces, objects, words, and the ability to recognize emotions in others. Sometimes you can see something called hyperorality, where someone is continuously putting something in their mouth. When we do our testing, we often see that when they're doing the drawing portions of the assessment, those are preserved. Another challenging part of frontotemporal dementia is that often these patients lack insight into their condition, and that makes it that much harder. They can't recognize all that is happening. That makes it really hard to plan and discuss. And this is one of the dementias that can have a little bit more of a rapid and progressive decline. The yellow on the slide is where we can see the changes in frontotemporal dementia. Here on the front part of the brain, the frontal lobes, as well as on the side lobes. And so you can see that the top back part of the brain where we have spatial processing, that's spared, and that's often why we see drawing preserved when we're doing our assessments in clinic. Here you can see brain scans that compare a normal brain, Alzheimer's dementia, and frontotemporal lobe dementia. The top is a PET scan where we see brain activity, which we measure with glucose metabolism. And that's represented with red, meaning the more red you see, the more active that part of the brain is. And below are CT scans, looking at the brain in a sagittal cut, which would be sort of if you remove through the top of the brain as a cut like this. And so you can see that there are differences in the folds of the brain tissue with more ridges, and you can see that there are areas of increased black as you move from left to right. That indicates that there's some brain injury and shrinkage. When we look at Alzheimer's dementia, you can see the sides where the temporal lobes are located have less red or brain activity and less gray material on the CT cut. And then when you see that, look at the frontal temporal brain, you can see less red coloring and brain tissue in the front of the brain as well as on the sides. And again, these images, along with the history, really help guide us into what's the most likely diagnosis. Lewy body dementia is one of several types of dementia that falls into a category that we refer to as Parkinson plus syndromes, meaning these dementias have symptoms that can resemble Parkinson's disease. Lewy body is one of the more common types within that category. It can be gradual to abrupt in onset. People can present with a triad of memory loss, Parkinson's symptom like a hand tremor or a specific type of walk, as well as REM sleep disorder. During REM sleep, that's where we have our vivid dreams, and our body is actually paralyzed. We don't move when we're having those vivid dreams. In REM sleep disorders, that changes and people's bodies move, and they can move their arms and legs. And often what you'll hear from someone's sleep partner or spouse is that the person is moving around in bed. Often people will say, I've even had to change rooms, it's gotten so bad. And they'll tell you it really seems like they're acting out their dreams in their sleep. And so that helps us sort of clue us in that this might be something that's going on. Often patients with Lewy body can have hallucinations like people or animals. And it can often be where their brain is tricked. And so sometimes they might say they saw a shirt on the floor in the closet, and for a moment they actually thought it looked like an animal, like a cat, until they realized that it was just some clothing on the floor. Because there are symptoms that are very Parkinsonian-like, this can really look like Parkinson's disease, and often a clue that something else may be going on is patients will be prescribed Parkinson medications and not have any response. Realize too that the patients with Lewy body dementia or under that Parkinson's umbrella can be very sensitive to certain medications. So sometimes if they're prescribed one of these sensitive medications, you might see worsening of the tremor, or they may become stiff in their arms or legs. And that history of being sensitive to medications can also help us with making the diagnosis. So with alcohol-associated dementia, the symptoms And whether or not it can be reversed really depend on the duration use and whether or not there are some vitamin deficiencies present. With slow chronic use over time, you can see short-term memory problems, confusion or balance issues. And on brain imaging, you can actually see changes in the architecture. But this can actually reverse with maintained abstinence over time. Often malnourishment occurs in the setting of alcohol use, and so we can see vitamin B deficiencies. So thiamine, which is vitamin B1, is deficient in a syndrome called Wernicke's encephalopathy. And that's where we see those same symptoms of short-term memory problems, confusion and balance. They're just much more severe. But realize that this can actually be improved with replacing the thiamine. And lastly, with alcohol use, there can be a disorder called Korsakoff Syndrome. And in Korsakoff's, there's a characteristic symptom that's known as confabulations, where people will give false information or talk about a false memory, and that's because they aren't able to make new memories or recall new information. These patients are completely unaware that they're confabulating. Their brain is sort of just filling in the gaps with information, and so it can be really hard to know if it's true or not. And this is a time when you really need someone who knows them well to be there to tell you that that it's actually not a true memory. So there are different stages to dementia. In our preclinical stage, this is where we don't see symptoms, but if you do some imaging or labs, you may see some changes. So researchers are really trying to target patients at this stage with some of the medications to try to prevent the symptoms of cognitive problems from the beginning. And next, remember, we have mild cognitive impairment, where we can detect memory problems, but because function and independence is not impaired, this is not a formal diagnosis of dementia. And remember, some people may or may not progress from mild cognitive impairment to dementia. And then when function and independence is affected, dementia is diagnosed, and there are 3 stages: mild, moderate, and advanced. And these are staged based on how impaired function is. And so someone who's needing some help with medications and finances would be more considered in the mild part. Having trouble getting dressed would be consistent with a more moderate dementia. Needing help to eat and really not walking much would be considered more advanced. Staging of dementia is important, and it helps describe the clinical progression. So clinically, it helps with communication about the disease and making management decisions. And staging is also important in our research setting, especially for clinical trials. And so I have listed here 3 staging tools: the clinical dementia rating tool, or the CDR, which is scale 0 to 3. That's commonly used in research, and the functional assessment staging, which is the FAST in stage 1 through 7. That's more commonly seen in our clinical practice. And while these tools can help with staging the severity of the disease, they are not intended to be used as prognostication tools or guides on how much time someone may or may not have. I wanted everyone to be aware that there's new terminology being used with diagnosing dementia. There's mild and major neurocognitive impairment, and that refers to the mental processes that are affected and whether or not function is impaired. It doesn't say anything about staging or the severity of the dementia. And possible or probable in the description refers to whether or not there's other information to suggest one type of dementia versus the other. I wanted everyone to be aware of this, because I had a husband and wife who came to see me in clinic a few weeks ago, and they were quite upset because the husband was just told that he had major neurocognitive impairment, and they thought that that meant he had advanced dementia. And what it really meant was that he had memory problems that were affecting his ability to function. So it was a major, not a minor or a mild neurocognitive impairment. I wanted to talk for a few minutes about another type of memory problem that you may or may not have heard about, called Chemo Brain. And this is a term to describe difficulty thinking and clearly after chemotherapy. But realize that people who have not received any chemotherapy can also have these problems. In fact, some people have attention, thinking, and memory problems before they have any treatment. People often describe this as feeling like they're in a fog where the outlines of thoughts are indistinct and it's really difficult for ideas to fully form. So their conscious thinking can be really difficult, and it takes a lot of effort just to complete a thought or come to a conclusion. There's many reasons for this. Stress of a cancer diagnosis can play a role, as well as if they're getting any radiation or if they've had any biopsies or brain surgery, as well as some of the treatments, chemotherapy, hormonal therapy, immunotherapy, as well as other medications they might be receiving during treatment, like antibiotics, steroids, sleep or pain medicines. There are common issues that can occur during treatment, like electrolyte abnormalities, dehydration, anxiety, and depression, and that can all affect cognition and memory. Those are things that are listed under those reversible causes on the slide I mentioned earlier. These complications during cancer treatment are all listed there, and so it's not uncommon for these patients to have some memory impairment during treatment. And often what I do now is try to help patients and families figure out if the memory problems they're having and they're seeing are due to something that's adverse reaction from their chemo treatment or a complication from chemotherapy, or whether or not there was underlying dementia present there before the diagnosis. Many people can feel off or think that they're going crazy with these symptoms, especially when they have a full evaluation and it's been unrevealing. So, so having one of those memory assessment tests like the MoCA or Minicog we talked about earlier may be completely normal. But what I can tell you is that if you or a loved one is experiencing this, you're not crazy, and this is not just in your mind. They have actually detected these changes on brain imaging. This is a positron emission scan or a PET scan that looked at, looks like glucose metabolism in the brain. This is actually from a study where researchers looked at brains of breast cancer patients before they started chemotherapy, and then again 6 months later. And on the second brain scans, they found significant decreases in their brain activity or energy use in areas responsible for memory, attention, planning, and prioritizing. So the front of the brain, the middle section of the brain, and I have those areas represented here with the red arrows. You can sort of see those are the areas where there's a little bit less activity. There are 10 facts to know if you're experiencing any kind of memory or cognitive change with cancer and cancer treatment. Realize that not everyone will experience this quote unquote chemo brain or fog. We're not exactly sure why this is, but one thought is that increased cognitive reserve, so robust brain activity, education, doing a lot of puzzles, that kind of reserve in our brain has been shown to be protective. We actually know that from our dementia research. Realize that some problems can get better as you treat the condition, and issues with attention, thinking, and memory can all get better, especially if we identify the cause, such as an electrolyte abnormality or medication. And if there's medication-related changes, those can improve with changing the medication, adjusting the dose, or just allowing people to have time for their bodies and brains to adapt. If the cause is related to cancer actually in the brain, that usually gets better with treatment. Some problems related to chemotherapy or radiation can last a long time, and research shows that these can take anywhere from 1 to 5 years after treatment ends to improve. But realize that some damage and some cognitive issues can be permanent. We can't necessarily predict this, but before saying something will or won't improve, patients should have treatment for this, and I'll talk about that in a few slides. And some people worry that chemo brain or cancer-related memory changes may increase the risk of developing Alzheimer's dementia. That's actually been studied and has not been shown to be true. And lastly, there are tips and strategies that we're going to talk about that you can use to cope and adapt if you or your loved one are experiencing some of these changes with cancer or cancer treatment. I wanted to circle back to this graph to show you how chemo brain fits into this picture. So remember, we have healthy age-related decline where we have some memory issues, but function and independence is not impaired. And then we have dementia memory changes that affect independence, and those do continue to worsen over time. And then we have chemo brain, where you start out with some memory issues that may actually affect independence. So someone might start to need help managing medications or managing their appointments, but these get better over time, and you can see that they actually can improve back to regain their function and independence. We've talked a lot about memory changes and ones that occur with aging and others that may or may not be more worrisome for dementia. And people often ask me when they or a loved one should be screened. What I can tell you is that as of 2020, the US Preventive Task Force concluded that there's insufficient evidence to recommend for or against dementia screening, a benefit that began in 2011 as a part of the 2010 Patient Protection and Affordable Care Act, made assessment of cognitive function a required component of your annual wellness visit. And so what I would recommend to you is that if you have concerns or you have family history, talk with your primary care provider about whether or not it makes sense for you or your loved one to be screened. So dementia is a complex and a terminal disease that affects both patients and their caregivers and family. It requires a comprehensive approach for management, starting with making the diagnosis, treating reversible or contributing disorders, and that may involve removing or avoiding potentially inappropriate medications. We need to promote brain health with exercise and a balanced diet, as well as stress reduction and memory exercises. Some patients may benefit from dementia-specific medications, and if behaviors are present, non-pharmacologic approaches really should be implemented. So while we cannot cure dementia, our goals are to preserve memory, maintain function, maintain independence for as long as possible while supporting our patients and their caregivers. And this point cannot be emphasized enough. Providing support to family and caregivers of people with dementia or memory impairments is an important part of the management and care. We know that caregivers and family have very important needs. Spend a lot of time providing unpaid care for loved ones with dementia or memory impairment. This is emotionally and financially difficult and can lead to social isolation and strain on relationships. We see a higher rate of depression in these caregivers, and the risk increases as the person with dementia's cognition worsens. It's a lot of strain and stress with providing care, especially around medical and nursing related tasks. Caregivers often feel like they don't have a choice in taking on the caregiver role. There can be mixed emotions when transitioning a loved one into a residential facility, as when the person with dementia enters the end of life phase. And all of this can take a toll on a caregiver's physical well-being. There's little time to exercise, eat healthy, sleep, and that leads to a caregiver's own lower quality of life, as well as increased risk of cardiovascular disease. These risks were shown to be higher for caregivers of persons with memory impairment than for those caring for older adults without memory impairment. One thing caregivers and their loved ones should think about doing regardless of the stage of dementia is talk with the medical provider who knows your loved one the best, that knows your loved one and their memory problems the best about advanced care planning. So previous research has shown that when we have these conversations earlier, patients feel like they have more autonomy and control. There's increased patient and caregiver satisfaction. There's improved quality of life. We can reduce stress and anxiety and depression in family members. We really don't want to wait until the last minute to have some of these conversations, but we also know too that not everything can be planned. But the point to make is the earlier you can have these conversations and get your loved ones input, the less stress and improved care, and your loved one can also feel like they are maintaining some control in a otherwise uncontrollable situation. So dementia is a terminal disease. These medications do not cure, but they can slow the progression. The effectiveness of the drugs can vary from person to person, and that can be limited in duration. The class of medicines called the acetylcholinesterase inhibitors are approved for mild or moderate disease, but realize donepezil is also approved for advanced disease. And these medications are thought to help by temporarily increasing the amount of neurotransmitter in the brain. But be aware with this class of medications, you have to monitor for GI side effects, low heart rate, almost passing out, as well as some vivid dreams. Memantine is something that's called an NMDA antagonist. And that's thought to help by inhibiting the excitatory neurotransmitter in the brain, which is glutamate. Glutamate's thought to sort of be overactive in dementia. Memantine is proved for moderate to severe dementia. Some people may start it earlier, but it hasn't actually been shown in studies to be effective at an earlier stage. If we're thinking about this medicine, realize that if there's any kidney issues, it needs to be adjusted. And some of the side effects can be dizziness, confusion, constipation, and headaches. But realize if we're considering starting one of these medications that they should be started in the outpatient setting and continued if improvement or stabilization occurs. Stabilization is something that would be noted by the caregiver's observations of behavior and memory, certainly a person's functional status, or performance on one of our testings like the MoCA or Mini-Cog. If there has been stabilization, these medications are stopped early, you may see a rapid decline as someone advances. But realize too that over time, these medications become less effective and it becomes more of a pill burden to take, and as well as may have some side effects. And so I always, counsel that when we start these medicines, we also talk about that there will come a time when we should think about slowly tapering off. And you should also think about that if someone is experiencing side effects. But remember that none of these medications available today for Alzheimer's dementia slow or stop the damage and destruction of the neurons that cause Alzheimer's symptoms. It's just that they may slow the progression. Your brain is a muscle, and just like physical exercise, it needs both rest and activity. And when you have an arm or leg weakness, you might go to physical therapy to improve the strength. Well, with memory loss, there's also a specialty called cognitive rehab to help improve your memory loss. And often this cognitive rehab is provided by occupational therapists or speech therapists, and they can create plans that help you adapt and cope with memory changes. Realize that repetitive exercises, memory and thinking exercises can help your brain repair the broken circuits that may contribute to memory loss. Carefully tracking your memory problems may reveal ways to cope. So if you become easily distracted, as we all sometimes do when we're hungry or tired, you can schedule difficult tasks that require concentration around a time of the day when you are feeling at your best. You may learn new ways of doing your everyday strategies to help you concentrate. For instance, taking notes, making an outline of the materials you're reading. Therapists can also help you learn ways to speak so that you commit conversations to memory. And stressful situations can make any memory problem worse. So having ways to reduce stress and end that cycle can help. And so we think about progressive muscle relaxation techniques, mindfulness practices, anything to sort of break that stress, memory impairment, worsening stress cycle can be helpful. Adjustments to your lifestyle can also help improve memory. So try keeping a checklist of your daily reminders and put it where you can see it. You may keep a copy at work or on your bedside table. Some people have found that they get ready for the next day by setting things out the night before. Some just general tips to consider, try doing one thing at a time and avoid stopping in between to do something else where you might get distracted from the initial task. Some people like to use word plays and rhymes to remember things. It's important to get plenty of rest. Sleep impairment can worsen anyone's memory. I can't emphasize enough exercise that helps your brain stay alert. So if you can walk, swim, garden, do yoga, that can also help you relax and clear your mind. But exercise your brain too. So doing puzzles and word games, painting, learning a new hobby or instrument. People are now becoming more technologically savvy and using their phones and iPads and calendars to make notes. And people are also placing sticky notes around the house to help them stay organized. People often wonder about the role of diet in memory loss or dementia. What I can tell you is that diet does make a difference. Research has shown that diets that help decrease our whole body inflammation can help with memory health. Specifically, when they looked at disorders that cause inflammation, such as diabetes, hypertension, high cholesterol, and smoking, those all increase inflammation in the cells and in our blood vessels that can lead to damage over time. So we think back to our vascular dementia causes. And so what they found is that so decreasing inflammation with the Mediterranean diet, with avoiding trans fats, having more legumes, fish, and grains can help. They also found that smoking alone increases the risk, and so they have found that with smoking, there's an 80% increased risk of developing Alzheimer's. So avoiding or stopping smoking also can help decrease risk. A good rule of thumb that I often emphasize is that what's good for your heart is also good for your brain. This involves exercise, and so people often ask, well, how much exercise? So if you can think about 5 miles a week or 150 minutes per week, that is what's recommended. The healthy diet, as I mentioned, certainly managing stress and maintaining good social connections. I know this is especially hard during COVID, but loneliness is actually a risk factor for memory loss. So trying to stay connected with friends and family the best you can help. And then remember, your brain is constantly changing. And so unused connections are going to get pruned away, and those that get used will get strengthened. And so I cannot emphasize enough to encourage you or your loved ones to engage in brain activities and puzzles. I'm not sure how well you can see it here, but at the bottom of the slide, I have some websites, Luminosity, AARP, Brain HQ. You can go to try to do download some brain exercises. I know I've talked a lot about many things this evening, and I hope you walk away with a little bit better understanding about the differences from healthy age-related memory changes and those concerning for dementia. Remember, when memory loss is affecting your function and dependence, you absolutely should seek further evaluation. There may be something reversible that we can find and treat. And one of the most important things you can do for your memory and brain health is really to adopt a healthy lifestyle, exercise, nutrition, and brain activities. And with that, I want to thank you for attending tonight. I really appreciate your attention. I'm happy to answer any questions or hear your thoughts.
Erin, thank you so much.
Gabrielle, you want me to stop sharing my screen for the question and answer?
That would be wonderful. Perfect. Now we're all joined together again. Erin, thank you so much for that. So much fantastic information that's so useful for all of us, taking us through normal aging, mild cognitive impairment. What is that line? And how do we describe moving from mild cognitive impairment to dementia with that change in level of function and independence in our day-to-day functioning? And then just describing all of those dementias. So thank you so much. We do have some questions, and everyone can feel free to add some more. We'd love to try to get to them. We have until about 7 tonight. So I do want to start kind of talking about that line, the movement from mild cognitive impairment into a dementia, and how you did describe in detail how it is that shift in functioning that we're looking for. Mm-hmm. And so Judy asked, is there any way to tell if someone will advance from mild cognitive impairment to Alzheimer's or a dementia?
It's a great question. It's actually one of the hardest things that we do, is sort of figuring out where someone is going to fall, as you know, Gabrielle, in the clinic. So the best way we have been able to predict if someone is going to advance to dementia is really people that have that mild cognitive impairment with short-term memory loss. So they call it amnestic memory loss. And so it's, that's different than, let's say that someone is having trouble like staying organized and planning tasks, and that's not affecting their function, but we certainly detect it on our assessments. People that have trouble staying organized, maybe they mess up a little bit of their clock draw, it's sloppy. Those people have been shown to be less likely to progress to dementia, but those with the short-term memory, so having trouble remembering the 5 words or the 3 words on our assessments, those are the ones that we sort of can predict may progress further. And ways we try to prevent it, certainly if someone, let's say, has a history of diabetes or high blood pressure, really making sure that they've got good control of blood pressure, good control of diabetes, counsel them to stop smoking, engage them in exercise and activity to really try to decrease some of that vascular inflammation are ways we try to protect. But the key is if it's a short-term memory, those are the ones that may progress, and about 12% will progress per year. And so I can't emphasize enough the challenge of this, and often what we just have to do is follow over time and see if someone tips over to where maybe they were struggling with medicines and using the pill box, and maybe they can maintain it, but maybe they've tipped to where now their partner has to take that task over, and that sort of tells us, okay, we've gone a step further into probably the mild dementia.
Thank you so much. And I kind of want to expand on that a little bit more for the care partners here. If someone's loved one has a mild cognitive impairment, they've gone to their provider, they've begun discussing it, and that's the term that they've heard, the diagnosis that they've heard. Is there anything that they specifically can do? Anything that they can look for, I guess, and monitor for as early signs of dementia. And one thing I'm thinking of as a clinician, as a nurse practitioner, is thinking about finances. So kind of which are those things that typically are important to look for as a care partner?
So looking for to see if things are progressing along. Mm-hmm. Yeah, so it's a real challenge even for us in practice, but noticing, maybe there's errors balancing the checkbook or the online finances, mixing up appointment days, calling someone by the wrong name and not recognizing to correct it, or realizing that you've used the wrong name or some of the wrong words can be concerning. But certainly if you've been given that diagnosis and you are thinking, how can I help protect my loved one? Healthy lifestyles, good sleep, avoid some of the medications that we know can tip people over. Get out walking. Managing mood. We know that depression is often called pseudodementia because often the symptoms of depression can mimic dementia, and dementia can cause depression. And so managing mood and loneliness are ways to help protect.
Absolutely. Thank you so much. I do want to ask Barbara's question. Can you discuss the brain disorder associated with COVID? Are you aware of this?
I am. There's a lot of speculation with with brain and COVID. I guess I don't know if you want to specifically talk about the pathophysiology of where things are injured or whether or not it can be improved. But it's what I guess I'll say is that we're still learning a lot about it. I don't think we have quite seen, especially in some of the longer symptoms, that this is going to improve. Certainly people that have had low oxygen levels or hypoxia, been in the hospital, been critically ill, that in of themselves can cause memory issues. You're just not as robust. And so COVID over on top of that, we know that in COVID there's high inflammation, there's vasculature injury. And so if you think about pathophysiology, so by that I mean what's causing the damage, there are many factors within COVID that place someone at risk for memory impairment. And I don't know that we have seen yet whether or not how reversible that is, but what we've been recommending here, what I've been recommending for those patients is addressing vascular risk factors, encouraging exercise and puzzles. And I get people in as early as I can to cognitive rehab. So I send them to occupational therapy and start working on those cognitive tasks.
Yeah, actually, somebody asked if you could elaborate a little further on cognitive rehab and how to find such services.
Yeah, so from what I have experienced, usually they're occupational therapists and speech therapists that help people work on coping and adaptive strategies. You can find them, usually people find them if they ask their primary care provider or their neurologist, psychiatrist about them. I haven't sort of seen groupings in Boston of providers that are specifically for that. I've just sort of seen them within the hospital systems and referred in. But they, depending on where people are having difficulty with their cognition, so if it's short-term memory, they work on ways to adapt with that. Some people have trouble with just remembering the correct names for things and naming things. And so they work with wordplay to help adapt to that. And certainly with, if someone that's got more issues with the front part of their brain, the frontal lobe, and sort of planning and executing tasks, they work on ways to break down tasks to manageable steps.
Thank you so much. And I know through my work as well that Mass General, the speech and language pathology department has cognitive linguistic therapy. So like you were saying, speech pathologists trained in this area. And so kind of asking about those types of things with your primary care provider team to see if your loved one can get connected. Judy asked, do puzzles and word games fall into the category of learning new things?
They do. So anything you haven't done before or not familiar with that you have to read and learn new instructions, those are all new tasks. There's been a lot of work to show when you start learning a new task, the levels of development your brain sort of go through from, first like sort of that functional memory where you have to actively think about, okay, I go to this website, I log on here, I type my name there, I do this. As you do that over time, that becomes more of an implicit knowledge to where you don't think about it. So if you think about, like, we all had to learn to tie our shoes, right? And most of us now do it without thinking about it. So there are stages of learning that our brains go through from learning a new task to then we've incorporated into sort of our everyday function. So anything that you haven't been doing normally, you'll first have to think about those steps. And so anything that you have to do that is considered a new task or new learning.
Wonderful, thank you. One care partner here shared that saying, my loved one has lost 20 pounds in the past 7 months and really can't afford to lose that type of weight. And they're wondering, is this because of the dementia?
So it's possible. So what I can tell you about weight loss with memory problems and dementia is that when dementia in the more advanced stages, people can have trouble coordinating and understanding the tasks of pick up food with hand and put in mouth and chew and swallow. And as the brain is failing, even the things we don't even think about, chewing and swallowing, can lose those abilities. So in the more advanced stages, it's absolutely common. If your loved one is more on the mild or moderate, or it's a relatively new diagnosis, there are some people that can forget to eat, some people that can have a change in taste, and then there are other sort of age-related things that can occur with ability to see contrast on a plate. So a white plate with mashed potatoes and parsnips and other white things, you can sort of lose the ability to recognize whether or not you're actually eating. But what I would highly encourage is, before we say this is from the memory loss, is get your loved one into your primary care provider and just do an evaluation, because there are so many things that can cause weight loss, and you would certainly hate to miss something, that can be reversible. So just as an example of that, with memory impairment, some people forget to actually go to the bathroom, and constipation can really impact appetite. And so there's many things. And so the short answer is yes, it could, but let's just make sure everything else is okay.
Such a great point. And I think we find that in a lot of disease processes. If someone has a major diagnosis, we still want to make sure we're screening for other things that could be going on as well. And so these things that you're astutely noticing, making sure that you're just raising that and bringing them up when you go and see the primary care provider, writing them down so you come with a list, so you're able to address those during your visits.
Yeah, and what I guess I'll add to that, Gabrielle, is that if someone has got mild or moderate dementia and has been relatively stable with their memory and functions over time, if you've come to me in a 3 or 6 month visit and you have lost that amount of weight, I'm actually worried something else is going on, because people don't usually lose that amount of weight that fast. The concern is 5% over 3 months, 10% over 6 months. And so it's sort of like when someone tells me that their loved one's dementia, let's say we're pretty certain his Alzheimer's has rapidly progressed over 3 or 6 months. Gabrielle and I both know is that dementia doesn't progress that fast with Alzheimer's. And so if you notice declines that quickly, we should look for something else going on, an infection, pain, they haven't moved their bowels, something else might be going on that's just making things a little bit worse.
Absolutely, thank you. Another great question here. Are there any implications if a specific type of dementia isn't known? So it's just kind of a diagnosis of dementia rather than a specific type, one that you've discussed today.
Sure. So the things we often counsel are just, knowing that there are more common types. So vascular injury and Alzheimer's, we often will encourage those recommendations that help decrease inflammation, help keep people active, have a healthy lifestyle and diet. And so we'll often make sure that at least those sort of, we'll call them core principles of management are being met, just to make sure, because oftentimes it's not just a straight vascular dementia. Often there may be something mixed in, and so we make sure we have the core things that we know can help keep brains healthy, just to try to reduce any other kind of insults that someone might be experiencing. And I'll say oftentimes we don't quite know the diagnosis. We just know that there's enough memory impairment that there is dementia present. We often don't know what's driving it, and so we have those core principles we try to go by of decrease inflammation, avoid inappropriate medications, have a healthy lifestyle, and make sure we protect the brain from any further insults.
Absolutely. And I'm seeing too in the chat that Nori mentioned she's a strong advocate for new learning in body-based activities like dancing, which is also wonderful for the brain.
Yeah.
So when we're talking about puzzles and all these other things, also wanted to talk about that, including the Ageless Grace class that she teaches on Tuesdays and Fridays. And if you're interested, just let her know and she can pass along some more information. Barbara brought up a really great topic, if you can just touch on it,
Sure.
Around driving and dementia. So you were talking about those instrumental activities of daily living, the laundry, the preparing meals, and driving falling within that category. So what would you say about that as this disease progresses?
So driving is an important part of everybody's independence. When we are unable to complete that, it can be so hard. And what I can tell you is that there are many providers who really struggle with making the recommendation that his or her patients don't drive. It can be so hard. The right thing to say is that if you're having memory problems to where you're getting lost, forgetting things, we really should think about not driving. And if you're not sure if you should or shouldn't drive, your primary care provider, your neurologist, your psychiatrist can refer you to someone to have a driving evaluation just to make sure you're safe. Driving varies by states, and so some states require by law if you have a history of memory problems or seizures or whatnot, that a provider may be required to report you to the DMV. Massachusetts isn't one of those states that requires that, but the last thing we would ever want for someone is to think that they are managing okay and get into an accident and someone to be hurt, and to have someone come back and say, I heard you have memory problems, I know you have memory problems, and try to have you at fault. That's the last thing we want. And so I just want to name how hard it is with driving, because that's such an important part of our independence and some who we are and our day-to-day activities. My recommendation would be if there's any concerns, have a driving evaluation. Just make sure that you or your loved one's safe.
Wonderful. And I love the idea of, pointing to safety. I know I frame that conversation in that way. We want what's best and safest for our patients, for, their care partners, and for those also on the road. So I think some of the most beneficial conversations we have are these really tough conversations. And so trying to navigate that and doing so with the help of people who are trained in this area and have knowledge of the area to support you through those conversations. And on another note of a difficult conversation and a worthy one, you mentioned advanced care planning. And I'm just curious if you could touch on that a little bit more. During your presentation, you mentioned the importance of early advanced care planning. Is there anything specific that's important to think about when you're doing that?
Sure. So realize that advanced care planning can cover a whole spectrum of conversations and decisions. I think commonly people think about, something called code status or resuscitation and being on breathing machines. That's certainly one end of the spectrum of advanced care planning. But realize too that there's another spectrum. So someone may say, when I lose the ability to really remember and recognize my loved ones, that's the time that I may or may not want to keep coming into the hospital. That's the time I'm going to want someone to come live with me. Like people, there is a spectrum, and advanced care planning should be discussed and thought about, for each stage of where you are with your memory and your function. So just to name that right away. So the driving conversation could be a part of advanced care planning. So what we know is that when caregivers are with their loved ones and their loved ones are in the hospital or at the end of life and they're not quite sure, would mom or dad want X, Y, and Z, it can be a lot of stress, and there can be a lot of stress from family members, and you can wonder about whether or not you are honoring your loved one, who they are and what their wishes are. And so we encourage people to try to have those conversations early to give your loved ones, your caregivers, some guidance on what you may or may not want. There are some things we know that don't necessarily show improvement in quality of life, survival, and those are things that center around feeding and nutrition. But that, just to say that that's another conversation to have. A lot of people will say, when I lose my ability to swallow, or I start having infections because I'm food's going down the wrong pipe, I would like you to do X, Y, and Z for me. So those are conversations to have, and you can certainly think about them in stages. To have all those conversations at the start of a diagnosis is overwhelming, and it's too much. So certainly think about having those conversations after there have been changes. Maybe there's been a slight change after a hospitalization, or you've noticed a slight change over a year, to think about those. But just to recognize that there's a whole list of things to discuss. Something that you may want to think about very early on, though, is making sure that you have financial things in order, wills are up to date, you have your healthcare proxy designated, have that done while you still can think through things clearly. And then once it's done, you put it on the shelf and it's complete. You don't have to think about it or talk about it, but at least the people who will be caring for you don't have to struggle through that when your memory is such that you're just not able to think through those things.
Yeah, thank you so much. Here's another question. Would returning to an instrument or foreign language to relearn after many decades hiatus be considered new learning?
That's a great question. So it's there. It's sort of that it's long-term memory that is there. So it's recalling our long-term memory, and so we'll call it like a sort of new, because there is a connection there that has probably faded, or we'll say pruned over time, that's faded, but relearning it strengthens, and it will strengthen that part of the brain and strengthen those connections. And so if it'll get you to do it, then I'll say it's considered new learning. But I think technically it's sort of, it would be strengthening what was once there on those synapses.
Sure, great. And someone asked, returning to the advanced care planning just for a moment, is there a resource that would provide information on how to start thinking about advanced care planning? And Nori mentioned the Conversation Project is a helpful resource for planning. Do you have any specific kind of go-to websites or books or anything on this topic?
Yeah, so I like the information that's provided on the Alzheimer's Association website. I like the conversations that Nori mentioned. I know that I think Susan Roulette and Barbara are on here, so our very experienced and skilled social workers, to make sure that we address this question. I would like to invite you guys also to chime in, because you both, and Chris, I think Chris is also on here too. All three of you do this and do it so well. So let's make sure that we have all the resources for everyone. What would you guys recommend?
I'll jump in too and just say prepareforyourcare.org is a wonderful resource. So you can consider that one as well.
Hi, Barbara here. I thank you, Nori, for mentioning Conversation Project. It's a fabulous website because it not only sparks the issues, but it even has specific questions that you can ask and fill in an answer to. And it's a very friendly website. By that I mean there are pictures and just helpful graphs and pieces of information. So I actually recommend that first and foremost, because in some ways, Dr. Stevens, it's, how do I say this? It's welcoming. It's a welcoming website too. It's very much alive.
Yeah. Thank you, Barbara.
Thank you.
I don't know if Chris or Susan wanted to add anything to that.
Yeah, I would also recommend something called the 5 Wishes document as well. It's a great resource in terms of getting, prompting the conversation, and also just beginning to think about, what's important, as we, grow and age. It's not a necessarily legal document in and of itself, but it can be a great tool as a jumping point for families to start thinking about, those decisions in the future. So again, 5 Wishes, you can actually go online and Google, or just Google it, and it'll come right up. But I found it very helpful in, working through those difficult conversations in the past.
Dr. Stevens, since you are also a palliative care physician, you are dual eligible and remarkable. Perhaps you can mention, underscore the very important role of a palliative care physician in guiding patient and family through that conversation. And it doesn't have to be at the end of life. It could be at any time.
Right. So with palliative care, we try to be involved in any serious disease as early as we can, so we can start thinking about and having these conversations. And we will often try to touch on these, especially at different stages throughout. And so, if someone has maybe progressed to where they're now needing some help bathing and dressing, that's a good place to check in. And it doesn't have to be figuring everything out at once, but sort of a gentle check-in to ask, how are you doing? What are your thoughts? Have you guys talked about, has anything changed? And so we try to walk this path with you, and give a little bit of education along the way of sort of some things to expect, so that when for example, when lung infections start reoccurring frequently, that's one of the signs that tell us we might be nearing the very later stages. And so we'll try to give education and guide you so that you might recognize, like, we're entering into this phase now, I should be thinking about and making sure we have done, X, Y, and Z.
Thank you. We have another question here, a little bit of a comment with some information, and then we can kind of see what we can gather from this. So a caregiver shared, my loved one has advanced Alzheimer's. We find that in late afternoon, he likes to look at books and sing the words loudly, wondering what is happening in his brain at that time.
That's a great question. You probably have all heard the term sundowning. And so there's this phenomenon that happens, in the late afternoon, early evening, where, people with some memory problems, even people without memory problems, can have this sort of shift in their attention, their thinking, their brain function. It can be hard to know what exactly is happening there. But just to say that we see that phenomenon quite a bit, I would say that singing and reading sounds very lovely. Often what we hear is that someone might become a little bit more aggressive or hard to redirect during that time. And I'm not sure if it's a fatiguing out of the day, there's some thought that that the day-night time cycle, and certainly our hormones in the body are sort of changing at that time, and that can throw some dysregulation in. It's really hard to know, but just to say that we see that.
Absolutely. Thank you for talking about that. And I think we have time for maybe one or two more questions. And if anyone has them, you can submit them now. Judy also mentioned something that I think we talk about a lot in care of those living with dementia. The power of music is very calming. And so we were just talking about the phenomenon of sundowning. You mentioned redirection. And I think that thought of the power of music being calming and that tool as redirection is really a wonderful one to try to utilize. We talk a lot, and Erin and I have spoken about this at length, that when there are, agitation or there are behaviors that are difficult, finding those redirective tools, if you can tap into them to calm your loved one, is really helpful. And so music being one, maybe grabbing a photo album and looking through some old pictures. Is there any other kind of tips or redirective activities that you found to be helpful through your career, Dr. Stevens?
Yeah, so just to say that music is so interesting. We know that, especially with Alzheimer's dementia, the sides of the brain, the hippocampus, tucked in the temporal lobes of the hippocampus, and that's where the damage occurs with Alzheimer's dementia, and where music is stored, and certainly our pleasure areas, the amygdala, those are preserved. And so I'm sure you all have seen the videos of people that are quite impaired, but you put music on and they calm and they sing and they seem to recognize it. It is amazing. And you mentioned looking at pictures, and I think the reminiscent therapy that we have talked about in the past, and sort of taking someone through, their familiar songs and familiar pictures can certainly be helpful. That's something that Kelsey has taught me, if Kelsey wants to chime in for some of her tips and strategies as well, to help redirect. But I will say that one of the things that I have found most helpful, and I found this most helpful even when I was in training, and we would spend significant amount of time in the nursing home, and I'd be asked to evaluate someone, they were worried about memory. I would just sit and watch, and I would try to understand what they're experiencing. And I would often find that it would appear like some folks, it really seemed like they thought they were at a train station, because they were going up to the nursing counter, and I think maybe causing some disruption, but it really looked like they were going to a train station. And that's because you would sort of get other clues that made them think that. Others I would notice, they seem to be doing a repetitive activity over and over, and we'd sort of figure out that for their work, that they were cooks or they did laundry, and so they were doing those kind of tasks over and over. So the first thing I would say is really spend some time, and maybe you all have already done this with your loved one, to try to figure out, like, what is it that we think they're experiencing or seeing or doing, and does it sort of fit into who they are and what they used to be doing? And if that's the case, I would try to maximize that. And so people that were busy and going around all the time want to stay busy, so give them tasks to be busy to redirect them. It might be that we just need to keep hands occupied. So squishy things to squish. So some of the PT balls can be therapeutic just to squish. Certainly folding things. Especially for some of the females and males that had a lot of young kids, if they have found that like the caring and nurturing and that task of I need to that caring for the baby doll can certainly help distract. Trying to connect with, so I find trying to connect with something of what they used to do, their life can help sort of ground them into who they are. But I would say that the most success I've had doing that is really just as best I can trying to understand what they might be experiencing.
Yeah, so really finding the personal touch, knowing that person and what they had been doing for the majority of their life, and how do you tap back into that?
Yeah.
Well, I just want to, again, thank you so much, Dr. Stevens. Remind everybody that this is being recorded just with the speaker views and the slides. And so you're able to share it with others if you'd like. It should be on the website in, Nori, is it about a week or so?
Give or take a week, week and a half.
Yes. So give it a little bit of time and then you can look out for that. So thank you all so much for joining. And I think Dr. Stevens will just stick around for another few minutes for anything else. And thank you again and enjoy the rest of your night.
Thank you, everyone.